Top Bed Talk.
So in the next 20 minutes or so, I would like to consider perioperative medicine from a physician's point of view. Of course, we're all familiar with the concept and the aims of perioperative medicine, which is a huge ask if we consider the fact that 10 million procedures are conducted per annum in the UK. And of course, perioperative medicine as a specialty does need to consider all surgeries and improving all pathways, but it's important for us to think about where the specialty, and particularly where physicians, may add most value. It's likely that the added value will be observed most in the high-risk group of patients. But when we're looking at defining risk, should we think about that in terms of surgery-specific risk? Or should we think about it in terms of risk of adverse post-operative outcome? And if we're thinking about it in terms of adverse outcome, should we base this on risk of adverse clinician-reported outcome, morbidity and mortality, or patient-reported outcome in terms of recovery or regret, or in terms of surrogate markers such as process measures and length of stay? And in actual fact, we can get hung up on that. But whichever way we look at it, from the perspective of clinicians, patients, or managers, the literature consistently picks out the following factors as independent predictors of adverse perioperative outcome. Poor physiological status, particularly cardiorespiratory baseline, the presence and severity of comorbidity, but even more importantly, multimorbidity, lifestyle and socioeconomic issues such as high BMI, smoking, alcohol, sedentary lifestyles, and increasingly the geriatric syndrome of frailty, which will be covered in much more detail by Dr. Jude Partridge later today. Of course, one of the problems in many of our patients presenting to surgical teams is that these issues may not have been identified or diagnosed prior to the patient presenting to the surgical units, and our pathways have to start to take this into consideration. What should our high-risk patients expect? Well, although our current perioperative pathways focus on assessment and severity of known conditions, it is increasingly clear, especially with the increasingly older surgical population, that we also need to screen for unrecognised disease and syndromes such as anemia, frailty, cognitive impairment. But also what's become clear is that we have to move on from just assessment and description of these issues to actually using that window, however short, for optimising the patient across medical, functional, social and psychological domains. Now, this requires a holistic view of the patient and an understanding of how to optimise individual issues, whilst taking the complexity of multimorbidity and syndromes such as frailty and cognitive impairment into account. It really is great to see so many of the new pathways that are emerging include prehabilitation. But many of these do focus on exercise, nutrition and psychological counselling, whereas probably our preoperative optimisation needs to be much broader than that, with a focus on medical and multidisciplinary optimisation. Because of course it is only once we have assessed and optimised the patient that we can really quantify risk and put that into the context of the benefits of surgery and facilitate shared decision making to plan the hospital admission. When it comes to the planning of the hospital stay, we often do plan the intraoperative and the immediate post-operative course in a lot of detail, noting the need for enhanced care, level 2 and 3 care, but we also need to plan for ward-based management because of course most of our patients are looked after on the general surgical wards by our junior surgical teams. For these patients, it's equally important that we describe the anticipated post-operative complications, how to spot them early, and how to manage them according to the latest medical evidence base. And that can allow an immediate focus on rehabilitation and timely and effective discharge planning, with clear handover to community teams for long-term management. And so if we reflect on all of this, it sounds like there really is quite a lot of medicine that's involved. And that can be illustrated by this fairly straightforward patient who attended a preoperative geriatrician-led clinic with a view to proceeding with a TURP. In this setting, screening was using a set of objective but simple to administer tools picked up on, firstly, a new diagnosis, Parkinson's disease, leading to investigation and optimization. The assessment also confirmed decompensation of a pre-existing diagnosis, which required treatment, but where the classical treatment options would cause interactions with the Parkinson's disease and therefore needed to be thought about and to be modified. Further assessment identified functional issues that required a multidisciplinary approach to optimization. And it's that kind of holistic approach conducted by one team that can then allow shared decision making. Because of course that also needs to take into consideration, firstly, capacity to consent, the patient's health literacy and their values, and then the provision of realistic choice to the patient. And the provision of realistic choice requires an understanding of the wider literature. For example, in the case of this gentleman, a fairly straightforward operation such as a TURP, sitting back and thinking about what is the evidence for benefit from this procedure for a patient such as him who is functionally dependent, and what are the chances of being catheter-free at 1 year. And really, we need that kind of background information if we're to honestly discuss the benefits, risks, alternatives, and the option of doing nothing in this situation. But of course, if this patient proceeds to surgery, most people like him will not go to enhanced care or to level 2 or 3 care and will be managed post-operatively on the surgical wards. And there it's important that the ward teams are alert to predictable complications, are able to pick those complications up early before they become severe, manage them in a standardized evidence-based approach with access to the appropriate multidisciplinary skills to make sure that this really is an uncomplicated admission and a safe discharge home with the outcome that the patient wanted. So, yes, it sounds like there's a lot of medicine that's required. And even in this relatively straightforward case, it sounds fairly complicated. So can we put models of care addressing these aspects of perioperative medicine into routine clinical practice? One such model, which has demonstrated that we can use these approaches, is the POP service based at Guy's and St Thomas's in London. In this model, patients are referred to POPs on the basis of surgical complexity, for example, all open abdominal aortic aneurysms or cystectomies come through to the POP service. Or they're referred on the basis of multimorbidity, frailty, cognitive impairment, functional dependency, or in cases where there is difficulty in decision making. Is surgery the right thing for this patient in the context of all of the other things that are going on? These referrals are normally instigated by the surgical team, but can come through from the community or from any other specialty or discipline. The patients are seen within 48 to 72 hours for the urgent referrals in a dedicated clinic where they are assessed and optimized using comprehensive geriatric assessment methodology, which I'm sure will be discussed in some of the other talks over the next couple of days. In this clinic, it's set up such that it is a one-stop service. Patients can have 24-hour tapes, they can receive intravenous iron, blood transfusions if necessary, bladder scans, all the kinds of common investigations and treatments that are required in this patient group. Most of the follow-up occurs primarily by phone or with community services. A lot of medicine happens in these clinics. For example, we know that 80% of our patients have their drugs changed. The team facilitate and deliver shared decision-making that's then clearly documented in a clinic letter using the brand format, and the letter also summarises all of the medical and multidisciplinary issues, providing a clear perioperative plan for the patient, for the GP, and also for the surgical, anaesthetic and ward teams. The team then discussed the patient at our weekly MDM, which is attended by our anaesthetic colleagues. If the patient proceeds with the surgery, then our team, the POPs team, will follow the patient through the surgical admission, providing hands-on management of medical issues, directing rehabilitation and facilitating discharge planning. This work on the wards is done through having daily presence during the week at joint handovers, ward rounds and board rounds, working together with the surgical teams within those settings. The perception of POPs is often that it's a service only for elective patients. And although we do see 1,600 patients per year through the service, actually the majority of the workload is conducted in the emergency group across a number of different surgical specialties at Guy's and St Thomas's, as well as in outpatient settings, inpatient settings, and in the community. So this model has now been running at Guy's and St Thomas's for 15 years. So it clearly can be done, but does it work? Well, the team have shown improved post-operative outcomes in orthopaedic elective surgery, through quality improvement work in urology, and then through an RCT in the vascular elective population. And this evidence has been gathered through original research and through local QI work. What's been really exciting has been seeing how this work is now being replicated from other centres which have established POPs-type services. And the other interesting thing is how we're now starting to see signals from big data studies, such as those conducted through NELA, the National Emergency Laparotomy Audit, showing possible relationships between reorganisation of pathways of care to include geriatricians, and showing how that appears to be related to improved outcomes. Of course, lots more work needs to be done to look into exactly how these improved outcomes are being delivered. So it does look like there is a role for physicians and that there is emerging evidence for benefit. But what about the cost? Well, for this, we're pleased to report newly analysed data demonstrating cost effectiveness for a CGA approach in a vascular elective surgical population, and hoping to be submitting that for publication in the very near future. I think it's really critically important that we, clinicians, don't spend time and effort reinventing the wheel. And so to support other physicians, whatever background they come from, whether that's from medicine, geriatric medicine, anaesthesia, intensive care, POPs has developed an interactive PDF, so an electronic resource which includes lots of the clinical documents, education and training programs, and management resources to help to support the development of similar perioperative services in other centres. And we think that this may be partly through this kind of sharing of resources that we're seeing a pretty rapid uptake of POPs-type services across the UK, with increasing evidence of collaborative working, both in the delivery of clinical care, but also in terms of developing pathways and protocols working together with anaesthetists and surgeons. And we know that these models of care are now being replicated even more widely, with a number of units internationally setting up POP services. So to me, one of the other things that, as a physician, that has become increasingly apparent over recent years is the need to rethink the way that we educate and train our workforce to ensure they are equipped to look after our patients, the majority of whom will have socioeconomic and lifestyle-related issues, who are multimorbid and frail, regardless of whether this is in the perioperative setting or whether we're thinking about it in these times of the COVID pandemic. But specific to the perioperative setting, we've tried to establish and address these issues around workforce by setting up new training programs for junior doctors, specialist doctors or specialist registrars, and also for allied health professionals, by establishing curricular, competency and capability frameworks and the resources to support education and training. So hopefully, in the last 20 minutes or so, you have seen things from a physician's point of view. That firstly, we need to make sure we understand the population having surgery and the complexity with which they present. That we have to match our skills to the needs of these patients, and developing these skills requires new approaches to education and training at undergraduate and at postgraduate level. That we really do need to challenge the old ways of delivering perioperative care. And this requires completely new ways of working, breaking down of silos, a rethink of the financial support that is required. And finally, that we must share good practice rather than reinventing the wheel, whilst making sure that we continue to gain evidence from the real world of clinical medicine, whether that's through original research or through employing quality improvement and implementation science. Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.